Hello, everyone. This is Tom Fox back again with Scott Endicott and Ben Locwin for another episode. Today, the title of our episode is Finding Hippocrates Within the Hypocrisy. But the question I wanted to pose to both of you is, what are some of the emerging healthcare trends that will be impacting our lives, both as patients, both and as family caregivers? Coming out of the pandemic, we had some, I think, very exciting developments, but I wanted to maybe get you all's thoughts, and starting with one of the more difficult decisions a family member has to make, which is the end of life decision. As you both know, I'm a lawyer by professional background, so I tend to see things through a legal lens. And so I very much see this through a legal lens of having an appropriate document in place and giving the decision-making power to whoever you want to make that designation, whether it's yourself or your family, or to make your wishes known before you're in a position where you can't make a decision for yourself, so your family does not have to make that decision. But you guys come at it from perhaps a little bit different perspective. So could you give us your thoughts on the end of life decision making?
Scott, you want to take this one first?
Of course, yeah. I always give pause just to make sure Ben has his opportunity there. When we talk about ethics, fundamentally what it becomes is about not necessarily right and wrong decisions, but the right best decisions, right? And so we think about this as more advocacy as a primary care option. And as our population gentrifies and skews much older, as frankly healthcare improves, does its job, as we become healthier as a population, as more people age longer, we move into this area where a lot of decisions that normally would have been managed by, frankly, the mortality rate 15 to 20 years ago have now been dropped in our laps. Decisions like what type of medications to take, quality of life versus end of life, which as we improve on a granular level, for instance, with immunotherapies, you run into drug approvals and therapeutic approvals that extend life maybe 6 months or 12 months successfully. But is that the quality of life that individual is seeking to have? You get into scenarios where, as you extend, and a good example of this, for instance, is prostate cancer and care of that condition. It's very much present in many males as they age. It's a significant portion of the population. And so aging actually creates a paradigm where you're going to generally come in contact with that, either you or as a caregiver. And there are a number of procedures that affect quality of life massively. And having just gone through it recently with a family member, there are decisions that are made and were made that will have healthcare impacts that are directly related to that quality of life and end of life decision that, frankly, were done in an organized way with a compassionate healthcare provider that have enabled a really, frankly, elegant transition process here. And that's the practical aspect of it, right? Is getting into the mix, being aware of how the data works, being aware of how individual products are advertised and organized. All of those things are becoming more and more important as you begin to understand that advocacy is a primary care option as healthcare shifts and changes. Ben?
Yeah, I think the idea of end of life is really at the crux of all this. Advanced directives, to me, are a crucial piece to this whole equation.
Yeah, great point.
And being able to document one's wishes while still capable and lucid to do helps bring, I think, a thread of logic to or through a sequence of events at the end of life that often seems so very illogical and unfair. We look at metrics such as one called QALY, which is quality adjusted life years. It's a measure of the state of health of a person in which you're looking at how much length of life is remaining, and it's adjusted to reflect the quality of life. So one quality adjusted life year is equal in that sense to 1 year of life in perfect health. And that measure is therefore sensitive to if one's health is impaired, what does that look like in terms of you may net yourself an additional year or 5 years of time, but you may have these impairments on top of that. And so that becomes a way to do the mental calculus of You may get more time, but is more time really the only thing you're looking for, or is it more quality of time? And that's why I think trying to go through this mental exercise while one is still in relatively good health and is capable of wrapping their arms or their mind around what all of this means to all of us, frankly, the family members, friends, caregivers, it's certainly an extraordinarily complex and emotional and ethically fraught situation where I think it's tough because to me that it's one area where it's a lot of gray space. There's not really a good black or white answer to this, and it's more navigating the minefield for each individual and what's best for each person, because one person's answer to that question about quality adjusted life years isn't the same answer that somebody else might have about it. And I think it's in our best interests to just look at those with whom we, share relationships with and try to make the smartest, most salient, most caring decisions we can for those who are in need. And quite honestly, of course, that boils down to each of our end of life decisions. And if we're all not patients already, we'll all be patients one day. So we all face that challenge.
And just further to that, to move the discussion, I think, to a logical next place, the one of the emergent options that's shown up is what's called clinical research as a care option. The acronym CRACO has become much more common now in the industry, and really, where that applies to is the other big C word with cancer treatment. Combination therapies, including what's considered to be traditional standard of care or standard approved drugs, are being combined, and you'll see this with, as very commonly we engage in the healthcare space, unfortunately, with a family member or ourselves with respect to oncology and cancer treatment. And CRACO is a great example of this sort of QOL versus EOL, right? The quality of life versus end of life, where there's becoming a very rapid change in the ability to combine therapies, including clinical research therapies and drugs with existing therapies. Most major oncology clinics like Mayo, we go across the board, right? Any of the major clinics across the US especially have this as essentially an embedded aspect where standard of care is now very much built around cutting edge, emergent, not necessarily approved therapies as an adjunct therapy to existing, to determine how well it works and seeing if there's an option to prolong end of life or hopefully prolong end of life with a reasonable quality of life. And so you'll hear that term clinical research as a care option. Thought it would be good to touch on that because it does speak to that ethical question of how far do you go? How far, what do you include and incorporate into that? And recognizing that clinical trials are there for a reason. Moving around those sort of barriers has its own cost to it. But when you're looking at extending life in that particular instance, there's a large degree of a hue and cry, if you will, from the patient base and the caregiver base to include that. So it's a good example of how personalized medicine and healthcare has changed drastically in the last 5 to 7 years.
Let me change the focus just a little bit to one of the developments that, frankly, I see as a hugely positive development, but not without some caveats, and that's telemedicine and the decentralization of healthcare. I live in a rural area of Texas, and although we're blessed with extraordinarily good healthcare resources, particularly for a mature population in my hometown, there are lots of places in rural areas in Texas where that care is lacking. And so I wanted to maybe ask you guys about your thoughts on telemedicine and this decentralization, and what do you think of this development, and are there concerns that we need to be aware of?
You mind if I take this one, Ben?
Please do.
And I'll be concise here. There are tremendous advancements and in the both the telemedicine and the decentralization of healthcare that have happened. And again, this is another post-pandemic change that we have to deal with. On the positive side, the diversity and access to healthcare, to your point, rural America, huge issue, right? Where hospital systems don't generally tend to go because it's a low profit area. the ability to manage a significant portion of your healthcare virtually through a multitude of options is becoming not just an option, but frankly, the best option in many cases. There is a better way of accessing healthcare when you have a paradigm that no longer includes you having to get in your car with a cold and sit in a waiting room with a bunch of other ill people with varying infectious diseases and other maladies that can affect your own health. On that level alone, there's an improvement option. Obviously, it comes with pitfalls, which have included everything from during the pandemic, there was a major issue with behavioral health medications being overprescribed because it's also very much easier to just show up on a 5 or 15-minute telemedicine call and have a doctor do an intake form. And you can't see this on podcast, but I used air quotes there. A doctor providing overprescribing, which harkens back to the opioid issues that just happened not too long ago. So there's a tremendous need to build, what do we want to call that, preventative measures into that, risk management measures to prevent this wonderful potential tool to create an expanded access to medicine through telemedicine and decentralized healthcare.
Yeah. And to tag on to that, I think the idea of telemedicine and decentralization of healthcare brings with it a lot of value. The upside benefits, as Scott mentioned, being of substantial value to patients in cases where they may not have transportation for a clinic visit or essentially across the board providing care to more people who otherwise wouldn't be seen or treated. So I think the treatment model expands greatly with the use of technology. There's some ambiguity in the data with telemedicine as far as, is it as effective? What about the nonverbal communication that may be conveyed in a clinical setting, which isn't conveyed as well over a video chat or over a telephone call? And I think those are certainly challenges that can be overcome as we get more and more advanced with this. And it's maybe not on a two-dimensional screen, but we're using virtual or augmented reality, for example. We can better mimic how a clinic visit would be in cases where you're doing it from the privacy of your home. So I see some of those barriers coming down in the not too distant future as technology gets even better. I think one of the downside risks, of course, is the data risks associated with it. I know Harvard Pilgrim recently disclosed a ransomware attack that occurred a couple months back, and that impacted 2,550,000 people. And you think about what kind of data might exist in the electronic health records there. It could be from telemedicine visits. It would include full names. It would include addresses, phone numbers, dates of birth, health insurance information, social security numbers, taxpayer identification numbers, and of course, everything else that's HIPAA protected, like clinical information, medical histories, diagnoses, treatments, dates of services, provider names. The flip side of the technology is that we're certainly not limited in the number of potentially nefarious actors who try to access some of this information as well. So I think we need to look with clear eyes at what are the benefits of this. And I think, as we've mentioned, there are many benefits. Potentially giving people who haven't been to a provider in decades the opportunity to get there virtually. It's incredible. And not being blind to the fact that there are also downside risks.
Gentlemen, unfortunately, we are near the end of our time for this episode. But before we leave, I wanted to ask you if our listeners wanted more information on yourselves or wanted to engage with you on any of the topics we've touched on this podcast, what would be the best place for them to do? And Scott, I'll start with you.
Scott Endicott. You can find me on LinkedIn.
And Ben?
Yeah, on LinkedIn or Google search.
Gents, thanks again. I look forward to continuing the conversation in our next episode.
Thank you, Tom.
Thank you, Tom.